Hi, it's Dr. Dave McCreary here from POCUS UK, and in this short video I'm going to show you how to find the paediatric appendix. There it is there. For this scan I'd always undertake it using the curvilinear probe initially, looking in the right upper quadrant for free fluid as shown here, left upper quadrant, and then looking in the pelvis where we can also see some free fluid. The main reason I like to use the curvilinear probe is to do a scouting view of that lower quadrant. So here we can see the iliac artery and vein shown in red and blue. But alongside that is this structure that shouldn't be there. It's this tubular or ring-like looking structure which I've highlighted in white, and this represented a fixed dilated enlarged appendix. So normally we wouldn't see this. I know it doesn't look like a great deal, but if you train your eye to look for something like this, this clearly indicated appendicitis to me. And then the next image we'll show the high frequency probe images, which was in fact an inflamed appendix. There it is, we can see the highly echogenic surrounding omentum and the fixed tubular structure. So this is actually me scanning my son's abdomen, who we noted had a very easy to find appendix when he attended for one of our ultrasound courses. I've put up the image of the different positions of the appendix. So this can obviously be post or pre-ileal, it can be pelvic, subcecal, or in many cases retrocecal. So I had to look up the evidence to see where the theory around so many retrocecal appendices came from, and this was a paper from the 1930s with over 10,000 cases, as well as two more recent studies with again large numbers, each of which show roughly 2/3 or more tend to have a retrocecal appendix. So I've found a few certainly, but I wouldn't say it represents the majority of my findings. This is an image just to show where the appendix can project from in a posteromedial position from the cecum and nestled between the abdominal walls. So what I'm doing here is I'm scanning using a high frequency probe with graded compression in a normal patient. With symptoms, we'd have to be very careful not to hurt the patient. And what we're looking for really in amongst loops of bowel is a structure that is non-compressible. It's much smaller than some of the adjacent bowel loops. Here we can see adjacent bowel loops peristalsing away, and then this circular structure central to that. So the edges are quite rounded and quite smooth. Sometimes you'll have this central white dot, which can represent a little bit of air within the lumen. Or of course we could see an appendicolith in a case of appendicitis. So being part of the GI tract, the appendix does have the classical gut signature with the 5 layers, from the outer serosa to that interface of the superficial mucosa and the air. But what the appendix doesn't have is the floral folding, the sort of irregular outline of the normal loops of bowel, such as the ileum as shown here. It'll be a very rounded structure. It's obviously incompressible, and it kind of remains regular throughout. This is a nifty little study which highlighted some maneuvers you can use in order to improve your visualization rates, which is to roll the patient in the left lateral position for 30 seconds before rolling them backwards. I've tried it sometimes and haven't had a great deal of success with it really, but it may be worth a try. Other things you can do is empty the bladder if it's filled, or to fill the bladder up if it's completely empty. So what I'm doing here is just using the graded compression. I'm in that kind of lower pelvic region, which is somewhere where I tend to start. I found a lot of pelvic appendicitis projecting downwards. And you can see there on the right of the screen, we can see the circular structure, which really doesn't move, it doesn't change shape. We've got the peristalsing loops of bowel next to it. But if you keep your eyes trained on that very, very circular tubular structure, we can see that that's the appendix. From that diagram where we talked about where the appendix can project to, it's worth noting in 3 dimensions that although it can be pointing up at 1 o'clock and across at 3 o'clock and downwards at 6, it may also be pointing backwards. So in other words, out of plane in a retrocecal appendix, for example. So what you have to do is rotate the probe, as you can see me doing there, showing the appendix almost in long section, and really maneuvering the probe in a combination of different angles. So sliding upward and downward, laterally and medially, as well as rotating, and as well as kind of rocking the angle in order to try to open out that appendix into the classical tubular structure that you can see. We can see here it appears to be behind the loop of bowel, where this peristalsing loop of bowel comes in before then revealing the appendix in a tubular fashion. Patience is key, because I did then rescan my son laterally and found a better view, as you can see there on the left of the screen, where we got the appendix in a complete tubular fashion. Now, the main reason people have attended the talk probably is to see what appendicitis looks like, and these are some of the features that we think about from a normal to an inflamed appendix. So much thicker walls, greater diameter than 6mm, and that surrounding inflammatory fat. We might put colour Doppler on and get a better Doppler pickup pattern. Certainly, normally we don't expect much pickup using colour Doppler. So here we can see in this first clip, we've got an appendix and transverse, probably with an appendicolith, creating a degree of clean shading behind it, centrally within the lumen. Everything around this is very, very abnormal. So the grossly inflamed echogenic fat and mesentery around it is, even if you drop your gain on your machine significantly, you almost can't make that disappear. It's so echogenic, as is in this clip. We know that this is highly, highly irregular. This was an image I took where we've got a very inflammatory fat-wrapped appendix where almost we can't fully make out the central structure of the appendix. Here, a probable perforations occurred whereby the walls have disintegrated. We can't exactly make them out, but we know this is highly, highly echogenic and inflamed. So in context, this would represent an appendicitis. If you're interested, we undertook a multi-centre study in our department and another department where we evaluated the diagnostic accuracy of POCUS for appendicitis, and we found it to be highly sensitive and specific. So if you're interested, you can go and check that out.